I am thrilled to announce our featured speaker, which is Dr. Eric Garland. Dr. Garland is a Distinguished Endowed Chair in Research and Distinguished Professor, Associate Dean for Research in the University of Utah College of Social Work. He's also Director of the Center of Mindfulness and Integrative Health Intervention Development, or C-MIIND. He's a developer of mindfulness-based therapy, which is founded on insights derived from cognitive neuroscience called mindfulness-oriented recovery enhancement, or more. He has been the recipient of more than $60 million in research grants and conducts clinical trials on mindfulness for addiction and chronic pain. He was appointed by NIH Director Dr. Francis Collins to the NIH HEAL Working Group to guide the HEAL initiative. In a recent bibliometric analysis of mindfulness research published over the past 55 years, he was found to be the most prolific author of mindfulness research. So very pleased to have Dr. Garland to present his innovative and exciting research. As Ashley mentioned, you can chat in questions and I'll be scanning those and moderating. So if we have some time at the end of Dr. Garland's talk, we can turn over some of those questions to him. Without further ado, Dr. Garland, welcome. Please feel free to screen share and dive into your talk.
Thanks so much, Dr. Donald, and thank you to Stanford and all of you in the Division of Pain Medicine for inviting me to give this talk. So I'm really looking forward to sharing my work with you. And there'll definitely be time for question and discussion at the end. So I'm going to share my screen. Oops. Let's see. Can you see my slides? Or can you
can.
Okay.
Yes.
Great. Thanks. So in 2015, Nobel Prize winning economists Case and Deaton found that for the first time in many decades, the US mortality rate was rising precipitously, to which they attributed in large part to the opioid crisis, a crisis that has been termed a disease of despair in the sociological and epidemiological literature. And I don't think, and this disease of despair has many sources, from the rising tide of income inequality to the lack of opportunity, to intergenerational violence and trauma, and the egocentric materialism of modern culture, which really was so empty of the humanistic values that's once guided our ancestors into a collective bond. And in the face of this vacuum of meaning, it was perhaps inevitable that life would become more painful. And indeed, rates of chronic pain soared in the United States, where an estimated 50 million Americans experience chronic pain each year. To alleviate this epidemic of pain, opioid prescriptions climb. And in 2015, 38% of the US adult population was prescribed an opioid that year.
Eric, I'm just going to interject very quickly. I don't know if you intend to have your notes displayed.
I don't, so thanks for
perfect.
You know. I actually don't need the notes, but they're up here. So let me see if I can figure out how to switch those. How's that? Is that better?
That is perfect.
Thanks, appreciate that. So this dramatic increase in opioid prescriptions was paralleled by a rising incidence of opioid misuse and opioid use disorder. And in 2020, 9.3 million Americans engaged in opioid misuse, and 2.7 million Americans had an opioid use disorder. Of the 9.3 million who misused opioids, 43.6% of those individuals obtained the opioids through prescriptions or a healthcare provider. And so these data indicate that chronic pain continues to fuel the opioid crisis. And these are both two intersecting diseases of despair. And I don't think the term disease of despair is a mere metaphor. I think it actually strikes right at the heart of the pathogenic mechanisms that are driving this crisis. So to understand this claim, we need to understand the role that hedonic dysregulation plays in pain, pleasure, and addiction. Traditionally, in Western philosophy, pleasure and pain have been considered opposites on a hedonic balance, such that increasing experiences of pain are thought to outweigh the experience of pleasure in everyday life. Modern neurobiology suggests that pleasure and pain are not mere opposites, but actually operate through a common emotional currency in the brain, mediated by the mesocorticolimbic dopamine circuit and the endogenous opioid system. And these same brain systems become hijacked by addictive drugs like opioids through an allostatic process in which chronic exposure to opioid use increases sensitization to pain, stress, and drug-related cues, and comes to outweigh the pleasure and meaning derived from naturally rewarding objects and events in the social environment. So in other words, as the individual becomes more and more dependent on opioids just to feel okay, they become less able to extract a sense of healthy pleasure, joy, and meaning out of everyday life. And this drives them to take higher and higher doses of the drug to preserve a dwindling sense of well-being. A downward spiral that leads to loss of self-control over opioid use, and that loss of self-control is characteristic of opioid addiction. But we know that not all patients misuse opioids or become addicted to them. In fact, most don't. So why can some people take opioids as prescribed, whereas other people go on to misuse them or become addicted to them? And this question has motivated a great deal of my basic science research. To answer this question, I use tasks from cognitive neuroscience, such as the dot probe task. In this task, there's a computer screen and it's split in two. On one side of the screen is a pain-related image. On the other side of the screen is a neutral image. These images are presented for a very brief amount of time, about 1/5 of a second, after which they disappear and a dot pops up behind one of the two images. The participant's task is to choose the side with the dot, and the computer measures reaction times. And there's a large body of research to demonstrate that people with chronic pain are faster to find the dot when it replaces a pain image than when it replaces a neutral image, providing an objective index of how much their attention is captured by or biased towards pain-related information. We also pair neutral images and naturally rewarding positive images. And we pair opioid images and neutral images. And several years ago, my research group was the first to demonstrate that people with chronic pain with opioid use disorder were faster to find the dot when it replaced an opioid image than when it replaced a neutral image, indicating that they have an attentional bias towards opioids. And this opioid attentional bias significantly predicted opioid misuse 20 weeks following the end of behavioral treatment. So these data suggest that opioid misuse is associated with increased sensitization to opioid-related cues, and that this has important clinical consequences. In my lab, we also measure hedonic dysregulation with the emotion regulation task. In this task, patients are presented with emotional images. In response to negative emotional images, they're asked to either view the image or to reappraise the image by reframing the meaning of the content of the image in such a way as to decrease its negative emotional impact. So to reappraise this image of this mother and child screaming in fear, one might think, the mother and child faced the tragedy, but in facing the tragedy, it brought them closer together as a family. In response to positive emotional images like this father and son at the beach, we ask patients either to view the image or to savor the image by focusing their attention on what is pleasant, beautiful, and good in the image, and appreciating and amplifying any positive emotions or pleasant body sensations arising in response to the savoring practice. And during this task, we measure an array of psychophysiological processes, including heart rate variability, which is the beat-to-beat variation in heart rate, driven by the parasympathetic nervous system and governed by a higher order network of brain structures involved in regulating attention and emotion. Several years ago, my colleagues and I found that relative to people with chronic pain who take opioids as prescribed, here depicted in the blue bars, opioid misusing chronic pain patients, depicted in the red bars, showed significant blunting of heart rate variability during reappraisal, viewing positive images, and savoring positive images, indicating that they have a selective deficit in their ability to shift their emotions in a positive direction. And we find converging evidence from EEG data collected during a similar emotion regulation task. Here in the top center panel, you can see brainwaves from a sample of people with chronic pain who take opioids as prescribed. These individuals are able to decrease their brain's reactivity to negative emotional stimuli with reappraisal. In the panel beneath, you can see brainwaves from a sample of people with chronic pain who misuse opioids. When these folks try to reappraise negative emotional stimuli, it actually, not only can they not decrease their brain's reactivity to those stimuli, but there's actually a backfiring effect, and the brain's reactivity to the negative emotional stimuli becomes more exaggerated. And all the way on the right, you can see brainwaves from collected during a positive emotion regulation task. So the blue lines represent brainwaves for patients who take opioids as prescribed. These individuals are able to increase their brain activity from viewing positive images to savoring positive images. The red lines are the brainwave response with people with chronic pain who have opioid use disorder. Here you see total blunting of brain response during positive emotion regulation. And these deficits in emotion regulation have important clinical consequences. They're associated with higher levels of opioid craving and predict future opioid misuse in people with chronic pain. So if opioid misuse and addiction are really being driven by hedonic dysregulation, then we need interventions that can target this mechanism. And to that end, I developed Mindfulness-Oriented Recovery Enhancement, or MORE, which is an integrative therapy that unites complementary aspects of mindfulness training, third wave cognitive behavioral therapy, and principles from positive psychology into a treatment that can simultaneously address addictive behavior, emotional distress, and chronic pain. MORE is a sequence treatment. It begins with a foundation of mindfulness training, which by virtue of enhancing attentional control and meta-awareness is used to synergize more elaborate therapeutic mechanisms like reappraisal and savoring, and ultimately lead towards self-transcendence, the sense of being connected to something greater than the self. These treatment components are intended to modulate a series of therapeutic mechanisms that are in turn intended to produce clinically significant change in a range of treatment targets relevant to chronic pain and opioid misuse. And I would add here that MORE has also been tested as a treatment for a wide array of addictive behaviors, including addiction to alcohol, illicit drugs, smoking, obesity, and even video game addiction. But today my talk is going to focus on MORE as a treatment for chronic pain and opioid misuse. I would also point out here that MORE is a manualized therapy. It's typically delivered as a group therapy, although we're currently also studying MORE delivered in an individual therapy context. I'd like to take one moment to talk about how we teach patients to deal with pain in the MORE intervention. People with chronic pain typically experience pain as an emotionally laden, monolithic, and unremitting experience. And on top of this experience, they lay a layer of suffering. They say to themselves, why me? This isn't fair. This pain is ruining my life. And this emotional suffering amplifies nociceptive processing in the brain. In MORE, patients are taught mindfulness skills to remove this emotional overlay and to decompose the pain experience into its subcomponent sensations. So rather than focusing on some terrible, awful anguish in the body, we teach patients to use mindfulness to zoom into that experience and to deconstruct it into sensations of heat or tightness or tingling, as well as to notice the spaces in between those sensations where there's either no sensation at all or potentially pleasant sensations right next to the painful ones. Using mindfulness to achieve this interoceptive awareness of sensation in the body may reduce emotional bias during pain appraisals and thereby decrease pain intensity and unpleasantness. And in MORE, patients are taught a similar technique to cope with craving, breaking the craving down into its cognitive, emotional, and sensorial components. Now I want to talk about another technique in MORE that makes this intervention quite unique. In session 4, patients are taught a mindful savoring technique, here depicted in this beautiful infographic developed by the National Center for Complementary and Integrative Health. So patients are taught to practice savoring by focusing mindful attention on a rose, appreciating the beautiful colors, textures, and scent of the flower, as well as the touch of its petals against the skin. And during this practice, patients are guided to cultivate a metacognitive reflective attitude and to become aware of, appreciate, and amplify any positive emotions or pleasant body sensations arising during the savoring practice. Then patients are asked to practice this skill at home with naturally occurring pleasant experiences in everyday life. And this technique is intended to amplify natural reward processing in the brain, induce positive affect analgesia, enhance positive emotions and the sense of meaning in life, and elicit experiences of self-transcendence, the sense of being connected of the self being connected to the world. So through this integration of mindfulness, reappraisal, and savoring skills, Moore aims to modify associative learning mechanisms that have become hijacked during the allostatic process of addiction by strengthening top-down cognitive control functions to restructure bottom-up reward learning from valuing drug-related rewards back to valuing natural rewards. So this therapeutic focus accords with my restructuring reward hypothesis, which states that shifting valuation from drug-related reward back to valuing natural reward will reduce craving and addictive behavior. And in my view, as both a scientist and a clinician, I believe that this therapeutic process of restructuring reward learning may be an essential process to recovery from opioid misuse and addiction. So I've given you a lot of theory, but let's get into the data. The first set of data I want to present comes from the original NIH funded randomized controlled trial of Moore as a treatment for chronic pain and opioid misuse. So in this study, there were 115 chronic pain patients who had been taking opioids for about 10 years. And at baseline, nearly 3/4 of the sample reported misusing opioids. And there were high rates of comorbid psychopathology in the sample as well. In summary of the findings, we found that Moore led to significantly greater reductions in pain severity and pain-related functional interference relative to a supportive psychotherapy control condition. And these effects were maintained by the 3-month follow-up, which was as far out as we went in this initial RCT of Moore. We also found that Moore reduced opioid misuse. There was a 63% reduction in the occurrence of opioid misuse symptoms, surpassing the threshold for opioid use disorder on the current opioid misuse measure, compared to a 32% decrease in the support group. And I would add here that these data clearly indicate that our control condition was an active control, but Moore was mo better. So sorry for the terrible pun. My kids would definitely accuse me of a dad joke about now. But you know, when you have an intervention called Moore, the puns just never end. There's always more and more. In this trial, we also attempted to get at therapeutic mechanism using the dot probe task. And we found the first evidence in the scientific literature from a randomized controlled trial that a mindfulness-based intervention could reduce the pain attentional bias. So after 8 weeks of treatment with Moore, patients' attention was less captured by, less fixated on the pain-related cue. We also found that among patients with an opioid attentional bias at baseline, Moore significantly reduced that bias. So after 8 weeks of treatment with Moore, patients found that their attention was less captured by, less triggered by opioid-related cues. But some of the most interesting data from this trial came from heart rate collected during the dot probe task. You can see here that across all 3 cue conditions of the dot probe task, patients in Moore showed significantly greater heart rate decelerations than those in the control group. To understand the clinical implications of these findings, we asked patients to rate their arousal ratings in response to the images. And not surprisingly, we found that heart rate decelerations were associated with reports of decreased arousal in response to the opioid and pain photographs. And that made perfect sense. But we found the opposite pattern in response to the pleasurable photographs. The more patients' heart rate slowed in response to the pleasurable photographs, the more aroused, the more stimulated the patients felt by the images. And we took this to mean that potentially Moore was increasing physiological sensitivity to natural reward. We conducted a heart rate variability analysis and found that across the board, Moore led to significantly greater increases in heart rate variability than the control group. but these effects were most pronounced to the pleasure cue condition. So you might be wondering, who cares about this psychophysiology? What's the clinical relevance of it? So to answer this question, we conducted a multivariate path analysis and found that the effects of more on reducing opioid craving were statistically mediated by changing the heart rate response to the pleasure cue condition, not by changing the heart rate response to the opioid cue condition, suggesting that more was reducing opioid craving by enhancing natural reward processing. And this represented the most significant scientific finding of my career to that point. I think you can appreciate the significance when you recall that the prevailing neuroscientific model of addiction, the allostatic model of addiction, states that as a person becomes more and more addicted, their brains and bodies become less sensitive to natural healthy pleasure, and this drives them to take higher and higher doses of the drug just to feel okay. So these data actually suggest that this allostatic process might be reversed, that by teaching people how to become more sensitive to natural healthy pleasure, this may reduce craving and addictive behavior. And these findings actually led me to crystallize my restructuring reward hypothesis. In this trial, we also collected ecological momentary assessments. So patients rated their pain and their mood state up to 4 times a day, every time they took their opioid medication throughout the course of treatment. So this gives you a tremendous amount of data, 224 time points per person. And we found that more significantly decreased pain intensity from moment to moment in everyday life. We also found that more significantly increased positive emotions from moment to moment in everyday life. In fact, patients treated with more had 2.75 times the odds of those in the supportive psychotherapy group to be positively emotionally regulated over the course of treatment. Interestingly, it wasn't the decrease in momentary pain intensity that predicted reduced opioid misuse, but rather patients who experienced the largest increases in the trajectory of momentary positive emotions showed the greatest reduction in opioid misuse, again providing support for my restructuring reward hypothesis. So let's just take stock here so that we know what we've learned to date about this intervention. So far we see that more seems to decrease addictive behavior, craving, and drug cue reactivity. And at the same time, more appears to decrease pain. And we see an indication that more is increasing positive emotions and enhancing responsiveness to natural reward. So given these promising findings, we conducted a second stage 2 randomized controlled trial of more to replicate these effects in a sample of 95 opioid-treated chronic pain patients in the primary care setting. And once again, we found that more significantly decreased pain severity and significantly decreased opioid misuse in this short follow-up period. We also found that more increased an array of positive psychological processes, including positive affect, savoring, meaning in life, and self-transcendence. Importantly, the effect of more on reducing pain severity and opioid misuse was statistically associated with increases in these positive psychological functions, suggesting that one way to treat the disease of despair of opioid misuse and chronic pain is to teach people how to savor natural, healthy joy, meaning, and self-transcendence in everyday life. And in this trial, we also found an indication that more was reducing opioid use. There was a 32% reduction in opioid dose by the 3-month follow-up in this trial. We wanted to understand the mechanisms underlying this effect. So we brought patients into the lab and we asked them to practice mindfulness meditation while we measured their heart rate variability, and found that patients treated with more showed significantly greater increases in heart rate variability during the lab-based mindfulness meditation task. But importantly, the effects of more on reducing opioid dose were statistically mediated by these increases in heart rate variability response during meditation. And given known linkages between heart rate variability and self-regulatory capacity, these data suggest that mindfulness may help patients to self-regulate their urge for opioids and to strengthen their self-control over opioid use. At the same time, we were interested in whether more could enhance outcomes among people with chronic pain and opioid use disorder who were being treated with medications for opioid use disorder. So my colleague Nina Cooperman and I were awarded a grant from the National Center for Complementary and Integrative Health to conduct a pilot randomized controlled trial of MORE as an adjunct to methadone maintenance treatment. We conducted this pilot trial in inner city New Jersey with a highly racially diverse sample. And we didn't expect to see significant effects in such a small sample, but we certainly did. We found that MORE significantly reduced days of opioid use, days of drug use in general, and also reduced pain and depression relative to patients undergoing methadone treatment as usual. And in this trial, we also collected ecological momentary assessments. And we used smartphones and we pinged people twice a day to rate their craving and mood state. We found that MORE significantly decreased craving intensity. In fact, it cut craving intensity by 50% by the end of treatment. We also found that MORE increased positive emotions from moment to moment. And again, we found that increases in momentary positive emotions were correlated with decreases in craving, providing additional support for my restructuring reward hypothesis. So let's take stock again. What do we know about the intervention? We see that MORE seems to decrease addictive behavior and craving, and MORE also appears to reduce chronic pain symptoms. At the same time, MORE appears to be increasing positive emotions and the sense of meaning in life. And MORE appears to be exerting these therapeutic effects by increasing self-regulatory capacity and eliciting experiences of self-transcendence. So given these compelling findings, we really wanted to get under the hood and start to understand the neurophysiological mechanisms by which MORE was producing its clinical outcomes. So to do so, we collected EEG data in a new sample of opioid-treated chronic pain patients while they participated in an opioid cue reactivity task. So here in the red line, you can see the brain's response to viewing opioid cues before treatment. And then here in the blue line on the left, you can see the brain's response to viewing opioid cues following 8 weeks of treatment with MORE. You can see that MORE significantly decreased brain drug cue reactivity in the late positive potential of the EEG. And on the right, you can see brainwaves from a sample of patients undergoing supportive group psychotherapy. Here you see no real difference in brain drug cue reactivity from pre to post treatment. And if you have trouble reading the squiggly lines, here's a bar chart that depicts the effect. A massive decrease in brain drug cue reactivity. These data represent the first findings from the scientific literature from a randomized controlled trial that a mindfulness-based intervention can reduce drug cue reactivity in the brain. So given the novelty of these findings and their significance, they were published in the high-impact journal Science Advances a few years ago. But in a second randomized controlled mechanistic study of 62 veterans with opioid-treated chronic pain, we found that MORE significantly increased EEG responses and skin conductance responses during viewing and savoring of natural reward cues, suggesting that MORE is enhancing neurophysiological responses to natural rewards. And further, in our Science Advances paper, we found that MORE increased positive emotional responses to images representing natural rewards. So images of smiling babies, lovers holding hands, sunsets on the beach. That patients, not only did their brains and bodies become more responsive to the images, but they also felt happier in response to those images. And the effect of MORE on reducing opioid misuse was statistically mediated by these increases in positive affective reactivity. Again, providing strong support for my restructuring reward hypothesis. So this brings me to the largest clinical trial of MORE conducted to date, and I have the pleasure of presenting these results to you today. This paper was published in JAMA Internal Medicine last month. So in this trial, there were 250 opioid misusing chronic pain patients who were randomized to receive 8 weeks of MORE or 8 weeks of supportive psychotherapy, both delivered in the primary care context, in the same environment where patients were receiving their opioid pain management. Patients reported an average pain of 5.5 out of 10 at baseline and had been in pain for about 15 years. Patients were taking high opioid doses at baseline, an average of 101 morphine milligram equivalents a day. 3/4 of the sample reported experiencing 2 or more chronic overlapping pain conditions, with the most common pain conditions being low back pain, osteoarthritis, and fibromyalgia. But I want to point out this was a highly heterogeneous pain sample. People were suffering from every kind of pain under the sun. There were also really significant rates of comorbid psychiatric conditions in the sample. Nearly 70% of the patients met criteria for major depression at baseline. 62% met criteria for a full opioid use disorder. 21% met criteria for a non-opioid substance use disorder. And there were high rates of generalized anxiety and PTSD in the sample as well. We monitored treatment fidelity very closely in this trial. My day job for many years was listening to hundreds of hours of tapes of therapists delivering this intervention to ensure that they were delivering both study interventions to a high degree of quality, and the therapists did an excellent job. Fidelity ratings were extremely high. In summary of the findings, using an objective index of opioid misuse that triangulates self-report, blinded clinical interview, and drug urine screen, Moore reduced opioid misuse by 45% at the 9-month follow-up point, more than doubling the effect of standard supportive psychotherapy. At the same time, Moore significantly reduced opioid use. In fact, 36% of patients treated with Moore were able to cut their opioid dose in half or greater by the 9-month follow-up point. And using ecological momentary assessments of opioid craving in everyday life, we found that Moore significantly decreased opioid craving from moment to moment. So these data indicate that Moore is a highly efficacious treatment for reducing opioid misuse and may also be useful for opioid dose titration as well. At the same time, we found that Moore significantly improved chronic pain symptoms and emotional distress through the 9-month follow-up. 50% of patients treated with Moore reported clinically significant reductions in pain intensity. And overall, the effect sizes that we observed of Moore in reducing chronic pain exceed those observed in meta-analyses for CBT, which is the current gold standard psychological treatment for chronic pain. At the same time, Moore significantly improved multiple dimensions of psychological health through the 9-month follow-up, including symptoms of depression and PTSD, as well as increasing positive emotions, mindfulness, meaning in life, and self-transcendence. And these findings support my mindfulness to meaning theory, which states that mindfulness, reappraisal, and savoring stimulate an upward spiral of positive cognition and affect to promote meaning in the face of adversity and enhance human flourishing. And these data also suggest that Moore is a broad spectrum treatment that can simultaneously address chronic pain, opioid misuse, and comorbid psychiatric conditions. But Moore also appeared to strengthen internal reward responses. So these are data collected by a computerized body map that was designed by my colleague Adam Hanley and myself. On this body map, patients locate pleasant and unpleasant sensations. Pleasant sensations are represented in blue, unpleasant sensations are represented in red, and the density of the hue indicates the frequency with which a given part of the body was identified as pleasant or unpleasant. This is a one-sided body map, so it represents the summation of pleasant and unpleasant sensations on the front and the back of the body. Here you can see that Moore massively increased pleasant sensations over time. And Moore also significantly shifted the ratio of pleasant to unpleasant sensations. So at baseline, patients reported experiencing about 1 pleasant sensation for every 4 unpleasant sensations. And I find that just really sad. It shows how much these folks were suffering. But by 6 months after the end of treatment with Moore, patients were reporting 2 pleasant sensations for every 1 unpleasant sensation, indicating that Moore radically modifies embodied self-representation, teaching patients how to internally generate, how to self-generate natural reward responses, and thereby shifting the sense of the body from being a place of anguish to becoming a place of refuge. And finally, we wondered whether experiences of transcendence evoked during deep meditative states might actually have an impact on addictive behavior. So in a recent mechanistic experiment published in Neuropsychopharmacology, we found in a sample of veterans with opioid-treated chronic pain participating in the MORE intervention that when we brought them into the lab and we asked them to practice mindfulness meditation while we measured their EEG responses, that those veterans treated with MORE showed significantly greater increases in frontal midline theta EEG power and coherence relative to those in a supportive psychotherapy control condition. Increases in frontal midline theta power were associated with reports of self-transcendence and mediated the effect of MORE on reducing opioid dosing. So frontal midline theta is a well-established biomarker of cognitive control, but it also increases during states of flow when self-referential processing is suspended and transcended during deep cognitive absorption with ongoing experience. These findings suggest that mindfulness meditation practice may actually provide a means of endogenous theta stimulation of the prefrontal cortex and thereby enhance inhibitory control over addictive behavior. And actually, we have a full replication of these effects in EEG data collected during the R01 funded trial that was published in JAMA Internal Medicine. So we're actually working on writing up these results for publication in another scientific journal. But in that study, we have data from 165 opioid-treated chronic pain patients showing the same pattern, that those who are treated with MORE show significantly greater increases in frontal midline theta EEG oscillations during mindfulness meditation. Increases in frontal midline theta, again, were correlated with experiences of self-transcendence and mediated the effect of MORE on reducing opioid misuse through the 9-month follow-up point. So having this replication across 2 separate samples, to me, provides fairly strong evidence that frontal midline theta may actually be a mechanism of the effects of mindfulness on reducing addictive behavior. So putting all this together, we see clearly now that MORE does decrease addictive behavior and craving towards opioids. And at the same time, MORE effectively reduces physical and emotional pain. But MORE also enhances positive emotions, natural healthy reward, and the sense of meaning in life. And these effects appear to be linked with increased self-regulatory capacity, cognitive control capacity, and experiences of self-transcendence. So taken together, this body of work supports my restructuring reward hypothesis, which suggests that increasing natural healthy pleasure, joy, meaning, and self-transcendence may come to outweigh the pull of drug-related reward and thereby reduce addictive behavior. So now I'd like to talk a little bit about the future directions of this work. So one direction that I'm working in earnest in is to identify the neurobiological mechanisms of MORE. To that end, I'm currently a PI on a NIDA-funded R01 to study the neural mechanisms of MORE as a smoking cessation intervention with a focus of MORE's effects on restructuring reward processing in the brain. I'm also an investigator on another R01 funded by NCCIH to study the neural mechanisms of MORE as a treatment for heroin addiction. In addition, my colleagues in Switzerland received a grant from the Swiss National Science Foundation to use PET to examine the effects of MORE on dopamine function in the brains of people with fibromyalgia. I'm very excited about that study and actually heading out to Switzerland next week to meet with my colleagues there and provide refresher training to the clinicians in Switzerland who are delivering this therapy. And finally, I received a meritorious score on a new grant to use fMRI to examine the analgesic and opioid sparing mechanisms of MORE as a treatment for chronic low back pain in patients who are prescribed long-term opioids. And this study is particularly important, not only in helping us to understand how MORE is inducing analgesic effects in people with chronic pain, but also how MORE is helping patients to self-regulate their opioid use, which actually is a question that hasn't really been answered by science yet. You know, how is it that a patient, when they're given a prescription bottle, are able to actually moderate their use and not take an excessive amount of opioids? What are the brain mechanisms that allow people to self-regulate that? So I think this should be really a fundamental contribution to the field, and I'm looking forward to pursuing this study. Another future direction of this work is focusing on optimizing more. We can see here across these multiple trials that more appears to be highly efficacious, but it doesn't work for everyone. There's still a significant subset of patients who are not getting relief from the intervention. So to extend Moore's reach, we're working to optimize the therapy by combining it with other neuroscience-based approaches, including neurofeedback and just-in-time adaptive interventions with wearable sensors. So I've currently been conducting a stage 1 pilot randomized controlled trial of Moore plus orbital frontal cortical neurofeedback using FNIRS. FNIRS is functional near-infrared spectroscopy. So this is an imaging modality that uses near-infrared light to measure changes in blood flow in the brain. And unlike fMRI, it's highly portable. It's essentially similar to an EEG system. So you're putting a cap on someone's head. You don't need to send somebody to the magnet, which is nice. This modality doesn't have the ability to go deep into the brain like fMRI, but it can localize activity to various parts of the cortex. So our protocol involves training people in Moore. Once patients have learned the savoring skill in session 4, we bring them into the laboratory for 3 neurofeedback sessions where we provide a real-time readout of brain activity from their orbital frontal cortex as they practice savoring a rose. As their OFC becomes more active, we play an auditory tone to signal to the patient that they're savoring correctly, and this will enhance the learning process of savoring. So let's see if I can play this audio clip for you and that you can hear it with me demonstrating our protocol. So the trial begins with a rest period to allow the brain to come back to baseline. Then when the instruction to savor appears on the screen, you can hear a tone. As my orbital frontal cortex becomes more active, here on the laptop, you can see activation in the right orbital frontal cortex as I savor the rose, becoming more intense. And my favorite part of this clip actually is what happens when the trial ends and I put down the rose. Watch listen to the sound and watch what happens to the spot of activation on the brain.
That's crazy.
So you can see that the effect is quite
really strong activation of the right orbitofrontal cortex.
Quite localized to the orbital frontal cortex, and quite remarkable. And our hypothesis is that providing orbital frontal cortical neurofeedback during savoring may actually facilitate the restructuring reward process and thereby produce improved outcomes in the reduction of chronic pain and opioid misuse. And we don't know that yet, but what we do know from initial findings from this pilot trial is that the neurofeedback is in fact working. So here's brain activation in a sample of opioid-treated chronic pain patients undergoing the Moore neurofeedback intervention versus supportive psychotherapy. Focusing here on the orbital frontal cortical region of interest, we see there's a significant group by time effect. And what's quite amazing here is this was during a positive emotion regulation task. So we're showing images of naturally rewarding cues on the computer screen, and we're asking patients either to view the image or to savor the image. And what we're seeing here is that this ability to savor, which we trained with a real physical rose in the neurofeedback sessions, is actually transferring to this positive emotion regulation task that involves viewing photographs on the computer screen. So there's this generalization and transfer of learning, which is really quite exciting. Now, whether this correlates with clinical outcomes, we don't know yet. And really, I think this is a call for the need for a much larger and more rigorous trial to unpack this effect, but it certainly is promising. Another direction that we're moving into is using just-in-time adaptive interventions with wearable sensors to extend the Moore therapy. So if you're not familiar with this concept, a just-in-time adaptive intervention uses technology to deliver a therapeutic intervention like mindfulness at just the exact moment when the patient needs it, for example, when they're experiencing stress. So in this trial, we developed a JEDI system using a commercially available wearable sensor, so a cheap Garmin smartwatch. It costs about $100 each. When the Garmin smartwatch can produce a physiological quantitative estimate of stress. When the smartwatch detects levels of physiological stress, one standard deviation in excess of the patient's moving average of physiological stress, it actually triggers their smartphone to ping the patient and to ask the patient, are you stressed? And then if you are stressed, would you like to practice mindfulness in this moment? If the patient responds affirmatively, then the app plays an audio recording to guide the patient to practice the mindfulness technique. So in a stage 1 randomized controlled trial involving 63 opioid-treated chronic pain patients, we randomized them to 8 weeks of more delivered by telehealth over Zoom versus an 8-week supportive psychotherapy intervention delivered by Zoom. And we gave patients these smartwatches. Patients and more were given the just-in-time adaptive intervention to remind them to practice mindfulness skills whenever they were stressed. And we found that the more plus JEDI intervention led to significantly greater reductions in opioid craving from moment to moment, and significantly greater reductions in pain intensity from moment to moment throughout the course of treatment and the 1-month follow-up point. We also found that when the patients used the just-in-time adaptive intervention, the use of the audio recording was associated with significant reductions in pain intensity, pain unpleasantness, opioid craving, and significant increases in positive affect in the moment. So these data also suggest that this system of combining more with a JEDI intervention can extend the reach of the therapy and improve clinical outcomes. And here again, now we need to scale this up to a larger trial, but the pilot trial is quite promising. So finally, another future direction that I'm interested in is to develop scalable versions of more that can be embedded into standard medical care pathways. I've done a lot of this work with my colleague, Adam Hanley, who I think is a real pioneer in this area. This work began with a study that I conducted about 5 years ago. In this trial, there were 244 hospital inpatients who were experiencing unmanageable pain from everything under the sun, including orthopedic traumas, diseases like cardiovascular disease, infectious diseases, neurological pain, burn pain, patients who had gone through surgery, and anything that would cause a patient to be suffering from unmanageable pain in the hospital. When they complained about the pain to their nurse, the nurse entered a flag on their medical record, which triggered a social worker from the hospital to come down to the hospital room and deliver one of 3 brief scripted interventions, either a 15-minute mindfulness meditation intervention extracted from the MORE therapy, or a 15 minutes of hypnotic suggestion, or a 15-minute pain psychoeducation control condition. And we found that the mind-body interventions reduced pain intensity by about 25% in the moment, which is comparable to the pain relief that would be produced by 5 milligrams of oxycodone. And so when I saw this, I just wondered if a simple scripted mindfulness intervention, 15 minutes long, could produce this much pain relief, then why aren't we embedding mindfulness interventions everywhere in the healthcare system where pain is encountered? So this led us to pursue the next study, which was to examine the impact of mindfulness in patients undergoing orthopedic surgery, and specifically joint replacement surgery. And we know that knee and hip replacements are supposed to increase by 200 to 400% by 2040. So just a huge increase in the number of these surgeries. And although these surgeries are often very effective, opioids are prescribed during these surgeries. And so this is a potential vector for the opioid crisis. So if we can intervene at this moment when opioids are being prescribed and reduce pain effectively while enhancing self-regulatory capacity over opioid use, maybe we can actually prevent some of this downstream epidemic of opioid misuse and addiction. So in this trial, 285 patients who were undergoing joint arthroplasty were randomized to receive either 15 minutes of mindfulness extracted from the Moore therapy, or 15 minutes of hypnotic suggestion, or a 15-minute CBT intervention. And we found actually that 6 weeks after surgery, patients randomized to mindfulness reported the largest increases in physical function scores on the PROMIS. And typically, joint replacement patients' 6-week physical function scores were very similar to their preoperative scores. But in this study, we found that patients who received mindfulness had physical function scores at 6 weeks after surgery that you would expect to see 3 months after surgery. So it appeared as if preoperative mindfulness training is actually dramatically accelerating the recovery process from arthroplastic surgery. And in a second clinical trial involving 118 joint replacement patients, we randomized them to receive one of 2 different mindfulness practices, either a mindful breathing practice or a mindfulness of pain practice extracted from the Moore intervention, the one that I described to you earlier that involves zooming into pain and deconstructing the pain experience into its sensory components. We found that both of these mindfulness interventions more quickly decreased postoperative pain intensity and pain interference and opioid use in the month following surgery compared to a brief cognitive behavioral intervention. So these data suggest that a single session of mindfulness training may actually be useful when delivered preoperatively to improve postoperative outcomes. But now we're undertaking a trial that pulls all of this work together. We're examining sequences of treatment, preventative mindfulness interventions preoperatively, combined with postoperative, more intensive mindfulness interventions to help patients who are still struggling a month after surgery. So my colleagues and I were awarded a DoD clinical trial award to conduct a sequential multiple assignment randomized trial, a SMART trial, to test these sequences of therapy. In the first phase of the trial, patients will be randomized to receive a single session of mindfulness versus usual care as part of their preoperative program prior to joint replacement surgery. Then we follow the patients 1 month after surgery, measure outcomes. For patients who are still struggling with chronic pain or prolonged opioid use a month after surgery, we re-randomize them to receive either another session of mindfulness training or the full 8-week Moore intervention. So we're really excited. This is a large study that's going to involve 500 patients on 4 military installations around the country. And this trial just got underway, and we're really thrilled to be conducting this methodologically sophisticated trial with real-world clinical relevance. So in conclusion, Moore is an efficacious treatment for addictive behavior, emotional distress, and chronic pain, as demonstrated by 5 randomized controlled trials involving more than 550 patients and multiple grants supporting this work. We've learned a lot about how Moore works over the past 10 years. Moore's mechanisms of action include reducing drug cue reactivity, increasing natural reward processing, enhancing meaning in life, and eliciting experiences of self-transcendence. Given Moore's efficacy, it's now time to move more towards real-world effectiveness trials and implementation research in integrated health systems to understand how best to deliver this therapy in the context of standard care. It's also time to disseminate Moore. To date, I've trained more than 500 clinicians from around the US and internationally in the Moore intervention, including social workers, psychologists, nurses, physicians, and physical therapists, many of whom are receiving insurance reimbursement for delivering Moore in the context of standard care. So now that I've conducted this efficacy research for more than a decade, I think it's really time to get the therapy out there. I really want to see it used widely around the country to help address the opioid crisis. And finally, teaching people to take in the good and mindfully savor natural, healthy pleasure may provide the learning signal needed to restore adaptive hedonic regulation and ultimately to reverse addiction. And I know that's a bold claim, but we're facing a severe crisis in this country. And I sincerely hope that this line of research has been somewhat useful in helping to address this problem. So thank you for your attention. I want to acknowledge the funders of this work, as well as my colleagues and lab who helped to bring this work to fruition. and love to talk with you and answer your questions.
Terrific. Thank you so much, Dr. Garland. We made visible the questions. Thank you, Ashley, for doing that. So I could read them to you, but if you're able to just open the Q&A, you'll see that there's 4 questions waiting for you. The first one from Dr. Marie Weil. She asks, how can psychologists become trained to deliver more?
Great. Yeah, happy to answer that question. So I conduct trainings and more several a year. Before the pandemic, they were all in person. Since COVID-19, we've been training people online over Zoom. And the training process is sort of, there's several steps to it. The first step is to complete a basic training, which is a 13-hour training. That will get somebody up to speed, where if they have the treatment manual, and more is a manualized treatment. So with the manual and the basic training in the hands of a competent clinician who already has experience treating people with chronic pain and opioid related issues, they'll be able to deliver this intervention with a basic degree of competency. There will be an advanced training piece, and then a fidelity monitoring piece that will be required for certification. But the basic training is 13 hours, and actually the next training is July 1st and 2nd, if you're interested. So just reach out to me.
Terrific, thank you. One more from Dr. Weil. Could you describe any of the factors that may be associated with retention of participants in the MORE groups over the weeks? What facilitates the participants coming back week after week despite the diseases of despair? Thank you.
That's a great question. So when we finished this, the large RCT of MORE that was published in JAMA, really the patients who dropped out of treatment didn't statistically differ from those who were retained in treatment at baseline, which was quite remarkable, but not very useful in terms of informing us about who's going to respond to this therapy. And that really is a very important question, not only for MORE, but also for the science of mindfulness in general. We really don't know who's likely to respond to these interventions and how to identify responders. And in fact, from clinically, anecdotally, I'd like to tell you that I could predict it, but a lot of times I'm tricked. People who I think at the outset are not going to be able to get this are sometimes the people who respond the most effectively to the treatment. So my short answer is we don't know. Fortunately, with the completion of this large trial of MORE, and I have a second DoD-funded trial that is going to be finished this summer, this is going to give us really a large sample, over 500 patients that we have fairly carefully phenotyped at baseline. And so one of the projects that I hope to work on is to look at the moderators of MORE's treatment effect, try to understand what are the characteristics that predict who's going to respond and who is going to drop out of treatment. And then once we identify those folks, we can figure out what sort of adjunctive therapies they need to help them either maximize their benefit from MORE or just to route them to another therapy. For example, Dr. Darnall's Empowered Relief Program would be a good choice. Figure out who's going to respond to what, and then get them the treatment that they need.
Terrific, thank you. One last question in the chat. Do the principles of MORE have the potential to prevent opioid misuse before it develops? Good
question. So we actually have looked into this with one empirical study. So in a 2019 paper published in the Journal of Consulting and Clinical Psychology, I presented these results a little bit earlier. We looked at MORE in a sample of patients with chronic pain who were prescribed long-term opioids, but who were not misusing opioids at the time they enrolled in the trial. And we were interested, could MORE prevent opioid misuse? And in this sample of folks, we did see some indication of that MORE could prevent opioid misuse, that actually over time, patients in the control group, their opioid misuse scores continued to increase over time, whereas those in the MORE group, their scores actually decreased. So suggesting that MORE may be useful in a prevention capacity, but this really needs to be tested in a larger, fully powered trial.
Terrific. Thank you so much, Dr. Garland, for a terrific talk. Oh, we have one last question. I noticed one of the investigated pain populations involved individuals in a burn unit. Does more assist with both sensory and nerve pain outcomes in addition to pruritus, as burn survivors tend to report challenges with all three sensory experiences? This is from Dr. Daniel Schneider.
Great question. So we did look at patients with burn pain in our study of brief mindfulness training in the inpatient hospital setting. The subset of patients with burn pain was a small subset, and so we didn't examine the intervention directly in that subgroup. There weren't enough of those patients to do a subgroup analysis. So I can't speak with precision to answer your question. I think that would be an excellent empirical question to test with a well-designed study. My suspicion is that yes, more would be effective for treating both sensory and nerve pain, as well as itch, because we're teaching a very similar technique to use mindfulness to cultivate interoceptive awareness of pain sensation and to undo pain catastrophizing, the negative emotional pain appraisals that could occur to these sensations. And my hypothesis is that when you strip away the emotional appraisal piece and get patients to focus on the sensation itself, in the absence of catastrophic cognitions or negative emotional pain appraisals, that you're going to see a reduction in pain intensity. I think it may be different in the context of acute burn pain than treating chronic pain. I think there, the nociceptive load is so high, and that even if the patient's not catastrophizing, they're hurting. So I would actually, I'd wonder if more would be less effective for a highly nociceptive event like burn relative to a chronic pain condition where the cognitive and emotional pieces are so salient. But I really don't know, and I think that would be a really good question to ask.
Great. And if you have just a few more moments, one last question from Brooke Franklin. What are some next steps in increasing the impact and ubiquity of mindfulness-based interventions in primary care or other medical settings? Great question.
I think that's a key question. And given the data that I presented to you, the fact that the JAMA internal medicine trial was conducted in the primary care context, as well as the earlier pilot trial in the primary care context, I think it's now time to move these interventions into primary care. So how do we do that? I mean, I think we need to develop models of care that actually work logistically and financially. I think one method that would work, and this is not just my spitballing here, but there are people in this country already doing this, is delivering more through the medical group visit model. So either the physician themselves or billing under the physician as part of a medical group visit for people with chronic pain. There are several large healthcare systems in the US that are doing this already. The largest one is Essentia Health, which is in the Midwest. They have a number of primary care providers who are delivering more as an insurance reimbursable group visit. So I think that's one model that would really work in primary care. Another is to train up medical social workers in those settings to deliver more, again, as a billable service, billing it as under group psychotherapy CPT codes, and doing this for patients, complex patients that are eating up a lot of physician time and costing the system increased cost in terms of emergency room visits, additional imaging requests, interventions, et cetera, and not getting a whole lot of relief. These patients could be referred to social workers who could deliver this treatment right in the primary care context, and really emulate what we did in our NIH funded trial. So those are some ideas I have about how this could be rolled out. In terms of the surgical care pathways that I alluded to before, we have kind of a vision of that as well, which is embedding very, very small bits of mindfulness in very scalable ways. For example, in the waiting, when the patient's in the waiting room, waiting to see their physician or their provider. Could you give them mindfulness on an iPad, for example, and guide them to start practicing the skills in that environment? I described to you the preoperative joint surgery preparation course, which is really required in many medical settings throughout the country. That's an ideal place to start delivering some of these interventions. Giving it to people in the hospital room after surgery to help reduce pain and postoperative opioid use. And then during the rehab process, I think mindfulness could be integrated into physical therapy. And I'm actually involved in several federally funded clinical trials that are looking at the integration of mindfulness into physical therapy as another vector, another site for administering this intervention and helping to improve health along this pathway to recovery.
Terrific. Thank you so much, Dr. Garland. We're going to pause there because I know you have some meetings that begin in about 5 minutes. But thank you again for being a featured speaker at the Stanford Pain Relief Innovations Lab. Thank you to everyone who joined us. And just as a reminder, our next speaker is Dr. Rebecca Houston on July 14th. We're also hosting Dr. Keith Humphreys and Dr. Howard Fields. Please visit our website to register. And thank you all. Have a great rest of your day.
Thank you.